In this video, you'll explore 5 carefully structured MCQs. The correct answer and the 4 incorrect ones are each thoroughly explained for real conceptual understanding. Let's begin.
A 58-year-old lady consults her internist with a 2-day history of low-grade fever and right upper quadrant pain. She admits experiencing nausea but denies any episodes of vomiting or diarrhea. Upon physical examination, she presents with pallor and jaundice. Her fever measures 38.3 degrees Celsius or 100.9 degrees Fahrenheit. She exhibits diminished air intake in the right lung and exhibits right upper quadrant discomfort without rigidity or rebound tenderness. Bowel sounds are within typical limits. The white blood cell count is 16,000 per cubic milliliter, and the urinalysis reveals no presence of red or white blood cells. What is the most probable diagnosis among the following options? A. Right-sided pyelonephritis. B. Right lower lobe pneumonia. C. High retrocecal appendicitis. D. Cholangitis. E. Gastritis.
The response is D. All provided illnesses may result in epigastric or right upper quadrant pain. However, the presence of jaundice renders cholangitis the most probable diagnosis. Fever, right upper quadrant pain, and jaundice constitute Charcot's triad and are strongly indicative of cholangitis. The bacteria involved in this infection comprise gut flora, specifically Enterobacteriaceae and anaerobes. The negative urinalysis contradicts the possibility of a urinary tract infection, while leukocytosis and fever would be atypical in simple gastritis. Upper abdominal diseases frequently correlate with basal atelectasis and occasionally sympathetic effusion, which explains the reduced breath sounds in this instance. Pneumonia in the right lower lobe may induce abdominal pain. Nonetheless, one would anticipate a cough accompanied by sputum production and evidence of consolidation upon physical examination. This patient requires abdominal ultrasound to assess the biliary tree in conjunction with broad-spectrum antibiotics. She may have endoscopic retrograde cholangiography, or ERCP, or surgical intervention to alleviate any biliary obstruction.
A man in his 60s comes to your clinic after experiencing 2 episodes of left-hand weakness. After being unable to move or use his left hand's fingers for hours, he gradually regained control. However, simultaneously, he had been experiencing right eye blurring. Presently, he is free of any symptoms. Among the following unusual physical findings, which one do you think is most likely to be present? A. A bruit at the bifurcation of the left carotid artery. B. A heart rate that is not regular. C. A bruit at the bifurcation of the right carotid artery. D. A murmur over the precordium that is pansystolic. E. A murmur over the precordium near the midpoint of diastole.
The response is C. Ophthalmic artery platelet embolization from an ipsilateral carotid artery plaque causes temporary monocular vision loss. The right internal carotid artery's constrictive ulcerative plaque at its origin may cause a systolic bruit over the bifurcation. Right-sided embolization to the upper limb motor area and cerebral cortex involvement may cause a transient right cerebral upper motor neuron lesion. Crossing pyramidal upper motor neurons supply contralateral lower motor neuron hand musculature, causing left-sided hand weakness. A bruit over the left carotid bifurcation would be associated with opposite effects. Atriofibrillation, characterized by irregular pulse rhythm, can lead to left atrial thrombus, resulting in peripheral emboli, including embolic vascular stroke. Transient ischemic events in the internal carotid distribution are more likely caused by carotid plaque than atrial fibrillation. There are two possible causes of a pansystolic precordial murmur: mitral incompetence or a left-to-right cardiac shunt. Neither of these causes is linked to embolic symptoms. Mitral stenosis, which is characterized by a mid-diastolic precordial murmur, is more commonly linked to cardiac failure than emboli.
A man in his 30s has been sick with a high temperature and a sore throat for a few days. Additional symptoms of hoarseness, difficulty breathing, and drooling have brought the patient to your attention today. On examination, the patient has inspiratory stridor and a fever. In your opinion, which option is the most suitable? A. Start treatment with ampicillin as an outpatient. B. Test for beta hemolytic streptococci by culture of the throat. C. Get an X-ray of the chest. D. Seek advice from an otolaryngologist and admit the patient to the critical care unit. E. Have a lab test for Epstein-Barr virus.
D is the correct answer. The onset of hoarseness, difficulty breathing, and stridor in this patient is consistent with acute epiglottitis. The patient needs to be admitted to the intensive care unit for close monitoring due to the potential for imminent airway obstruction. Indirect laryngoscopy or neck soft tissue X-rays, which can reveal a swollen epiglottis, can confirm the diagnosis. A consultation with an otolaryngologist should be sought. H. influenza is most likely the causative agent. Ampicillin would not be effective against many of these bacteria because they produce beta-lactamases. As a first line of defense, you could prescribe a beta-lactamase-resistant semi-synthetic penicillin or a third-generation cephalosporin. The infection does not spread to the hypopharynx and larynx, although streptococcal pharyngitis can produce severe pain when swallowing. Instead of a chest X-ray, lateral neck films would be a better choice. The thumbprint sign is a common finding on lateral neck films. Although stridor is not a common symptom of infectious mononucleosis, it does cause exudative pharyngitis and cervical lymphadenopathy.
A patient with long-term type 2 diabetes mellitus who is 70 years old seeks medical attention after experiencing left ear pain and purulent drainage. The patient is not feverish according to the physical examination. There is swelling and edema in the external auditory canal, and the left ear's pinna is painful. A normal white blood cell count has been detected. The pus-filled drainage is probably caused by which of these organisms? A. Pseudomonas aeruginosa. B. Streptococcus pneumoniae. C. Candida albicans. D. Haemophilus influenzae. E. Moraxella catarrhalis.
A is the answer. Ear pain and drainage in elderly diabetics may indicate malignant external otitis. Swelling and inflammation in the external auditory meatus strongly support this diagnosis. This infection is typically caused by P. aeruginosa and affects older, poorly controlled diabetics. It can invade facial nerve and temporal bone and cause meningitis. Streptococcus pneumoniae, H. influenzae, and M. catarrhalis generally cause otitis media, but not external otitis. Candida albicans rarely affects external ears.
A 30-year-old man presents with right upper quadrant, RUQ, pain. He has been well except for an episode of diarrhea that occurred 4 months ago, just after he returned from a missionary trip to Mexico. He has lost 7 pounds. He is not having diarrhea. His blood pressure is 140/70, pulse 80, and temperature 37.5 degrees Celsius, 99.5 degrees Fahrenheit. On physical examination, there is RU2 tenderness without rebound. There is some radiation of the pain to the shoulder. The liver is percussed at 14 centimeters. There is no lower quadrant tenderness. Bowel sounds are normal and active. Which of the following is the most appropriate next step in evaluation of the patient? A. Serology and RUQ ultrasound. B. Stool for ova and parasite.
C. Blood cultures. D. Diagnostic aspirate. E. Empiric broad-spectrum antibiotic therapy. The answer is A. The history and physical examination suggest amoebic liver abscess. Symptoms usually occur 2 to 5 months after travel to an endemic area. Diarrhea usually occurs first, but resolves before the hepatic symptoms develop. The most common presentation for an amoebic liver abscess is abdominal pain, usually in the RUQ. Amoebic serology using enzyme immunoassay is a sensitive test and is positive in more than 90% of patients. Ultrasound has 75 to 85% sensitivity and shows abscess with well-defined margins. Stool will not show the trophozoite at this stage of the disease process. Blood cultures and broad-spectrum antibiotics would be ordered in cases of pyogenic liver abscess. But this patient's travel history, the chronicity of his illness, and his lack of clinical toxicity suggest entamoeba histolytica as the probable cause. Aspiration is not necessary unless rupture of abscess is imminent. Metronidazole is the drug of choice for amoebic liver abscess.